Welcome to the Deep Dive, the place where we cut through the noise and deliver high-impact knowledge directly to you.
Hello.
Today, we are strapping in for a really high-speed tour of the central nervous system. It's the body's command center, and we're going to focus on 5 of the most challenging neurological conditions that affect millions of people all over the world.
That's right. Our mission today is to give you a clear, a synthesized roadmap of Alzheimer's disease, Parkinson's disease, epilepsy, meningitis, and migraines.
And we're not just reciting definitions.
No, not at all. We are extracting the most important insights on the pathology, the symptoms you absolutely have to watch for, and of course, the crucial strategies that maximize quality of life and safety.
We've organized this deep dive around 4 critical themes, really based on what the sources prioritize in terms of functional impact. So we'll start with the long-term chronic conditions that affect cognition and mobility.
Right. Alzheimer's disease will be our main example for cognitive decline. And then Parkinson's disease as well. It's the devastating illustration of mobility loss.
And then we pivot to the more acute neurological events.
Yes, the rapid threat of infection, where we'll focus on meningitis, and then the chronic neurovascular problem of pain, which we'll see through the lens of migraines.
Understanding the underlying mechanisms in all 5 of these is just so critical for recognizing those early signs and managing potential crises.
It really is.
So let's just jump straight in. We'll begin with part 1. Mapping the slow structural collapse of the brain with a deep dive into Alzheimer's disease.
Okay. So when we talk about conditions like Alzheimer's, we first have to ground ourselves in the terminology.
Right.
Dementia is the big umbrella term. It's a chronic confusional state, and it describes the progressive loss of brain function that leads to impaired cognition.
And there are many different causes of dementia.
Many. And Alzheimer's disease, or AD, is the specific disease process that's responsible for the largest share of those cases. It's the most common type, and it typically affects people over 65.
It's probably helpful to understand what AD isn't, too.
Yes. For instance, vascular dementia often gets confused with AD.
How is that different?
Well, vascular dementia doesn't come from these structural plaques and tangles we're about to talk about. It comes from disorders that decrease blood flow to the brain, like a series of small strokes or chronic vascular disease.
So it's an oxygen problem.
It's an oxygen problem.
Huh.
Those repeated lack of oxygen events cause damage. Sometimes it's called multi-infarct dementia. But AD is different. It's a primary structural and chemical destruction.
Okay, let's get into that structural destruction because this is really where AD becomes unique. The sources describe these 2 pathological hallmarks that are, they're physically jamming up the brain's communication system.
Correct. Imagine your brain is a massive network of electrical wires. The first problem is what we call neuritic plaques.
Okay.
These are sticky, toxic clumps of a protein fragment called beta amyloid. They build up outside the neurons, especially in the hippocampus.
And the hippocampus is central for memory, right? Mm-hmm.
It's the central hub for forming new memories. These plaques, they act like gunk, physically clogging the synapses and impairing the normal transmission of signals between neurons.
So if the plaques are the gunk outside the wires, the second problem, these neurofibrillary tangles, that's what happens when the internal structure of the wire itself just twists and collapses.
Exactly. Inside a healthy neuron, you have these supporting structures, and they're stabilized by a protein called tau.
Okay.
In AD, this tau protein becomes abnormal, and it twists into these fibrous tangles. The whole structural support system just collapses, and the neuron's internal transport system is destroyed.
So the cell can't get nutrients or send signals.
Right, and when that happens, the cell can no longer transmit electrical impulses or nutrients, and that leads to cell death.
So it's fundamentally a failure of architecture, but the sources also make it really clear that this structural breakdown has a chemical consequence, and it specifically hits memory so hard.
Oh, absolutely. The regions involved, especially that hippocampus we mentioned, the heart of recent memory, they rely very heavily on neurotransmitters, particularly one called acetylcholine.
Acetylcholine.
As the beta amyloid accumulates, it directly interferes with the production and uptake of that acetylcholine. It effectively turns down the volume on the brain's ability to learn new things and retrieve recent memories.
So the structural destruction triggers a critical chemical deficiency.
That's it. And that results in the characteristic memory loss of AD.
Now, while the pathology is clear, the etiology is, it's complex. Age is obviously the overwhelming risk factor. The stats are pretty staggering. 1 in 9 people over 65 has AD.
And it is tragically the sixth leading cause of death among older adults in the U.S. But we know it's not just age.
Right. We often talk about genetics, but the genetic link isn't a guaranteed one-to-one inheritance, is it?
No, not at all. The most established genetic factor, especially in the white population, is the apolipoprotein E gene, or APOE, specifically the E4 form of it.
And what does that gene do?
APOE is involved in transporting cholesterol, and carrying this E4 variant just increases your risk. But, and this is big good, but possessing it only raises the probability.
Right.
It is not a diagnosis sentence.
I say.
Familial AD, which is the rare, strong genetic inheritance, that's usually responsible for the early onset cases. People diagnosed before 65 or even 40.
I found the hormonal research really compelling. This idea that decreasing estrogen in women after menopause might be a mechanism that actually accelerates the disease.
This is a major area of research, and it's so important because older women are statistically more likely to develop AD than older men.
So what's the theory there?
The theory suggests that increased follicle-stimulating hormone, or FSH, during menopause binds to tau receptors on the neurons. And this binding seems to activate a cascade that directly accelerates the formation of both the amyloid plaques and the tau protein tangles. It creates a very plausible biological link between reproductive aging and neurological risk.
And beyond our internal biology, the external world matters hugely. The sources connect major physical and emotional trauma to an increased risk. I'm thinking about traumatic brain injury, TBI, and PTSD.
TBI is a recognized risk factor. It can initiate or accelerate that accumulation of tau protein. And this is especially relevant in groups like military veterans.
Right.
Studies on veterans have shown that those exposed to severe chronic stress that leads to PTSD or those exposed to chemical weapons, they demonstrate measurable decreased brain volume in critical areas associated with AD.
So it highlights how a physical insult or profound psychological stress can create this long-term neurological vulnerability.
Exactly.
And this is where we absolutely have to pause and address this giant synthesizing insight from the source material, the direct connection between social determinants of health SDOH and the stability of the central nervous system.
This is perhaps the most critical takeaway for our listeners today. The data is just unequivocal. Black individuals have twice the risk, and Hispanics have 1.5 times the risk of AD compared with whites.
And this isn't purely genetic.
No, it's driven by systemic, measurable disparities.
What are those specific SDOH factors that compromise neurological stability? What are we talking about here?
Well, they include things like lower socioeconomic status, low educational attainment, employment in physically demanding manual labor jobs, also chronic lack of food security, decreased social interaction leading to isolation, and persistent excessive stress.
So things that cause inflammation.
Exactly. Chronic low-grade inflammation, which is often tied to poverty and lack of access to care, is a known risk accelerator for AD.
So if you live in an environment defined by food insecurity and chronic high stress, your brain is measurably more vulnerable to structural collapse later in life.
That's what the data suggests.
It just reframes health equity not as just a social issue, but as a direct neurological protective factor. That connection is truly powerful.
It is. Now, to manage AD, we categorize this progression into 3 general stages. But it's important to remember that the journey is chronic and often nonlinear. A patient can show overlapping symptoms.
Let's define the early stage, or mild AD. This must be the hardest one to spot, because the symptoms can be denied or disguised.
They often are. In this stage, patients are still largely independent in their activities of daily living, their ADLs. The hallmark is short-term memory loss.
Forgetting names, misplacing things.
Forgetting recent conversations, misplacing items, difficulty learning new information, and crucially, they may show subtle personality changes, often a loss of initiative or enthusiasm, which leads to less engagement.
This is also when the communication hurdles start, which caregivers really have to understand. We're talking about the 4 A's of cognitive deficit.
Yes. The first is anomia. That's the inability to find the right words, so you see hesitation in their speech.
Okay.
The second is aphasia. These are problems with language itself. It can be difficulty understanding, which is receptive, or difficulty speaking, which is expressive.
Third
is apraxia. This is the loss of familiar, purposeful movements. It can show up as a motor speech disorder or just an inability to do simple tasks like tying their shoes.
And the last one is agnosia.
Agnosia, the loss of sensory recognition. They can see a familiar object, like a fork, but they can't recognize what it is or what it's for.
Wow. Now, moving into the moderate stage, or moderate AD, the disease stops being a subtle inconvenience and it becomes a debilitating, life-altering condition.
Absolutely. This stage involves the impairment of all cognitive functions. The patient becomes significantly disoriented to time and place, often struggling with basic tasks like managing their finances.
And the visuospatial deficits become dangerous.
Very dangerous. They can't interpret their surroundings, which leads to difficulty driving and getting lost easily. Their dependence in ADLs rapidly increases.
And the behavioral challenges, they amplify here too, right?
They do. Increased agitation, depression, and mood swings are very common. The language deficit deepens, speech becomes less fluent, their vocabulary shrinks, and they eventually become fully aphasic.
And incontinence starts here too.
Bladder and bowel incontinence typically begin. And psychotic behaviors, including paranoia and hallucinations, can start to appear, which places an immense strain on caregivers.
And finally, the late stage, or severe AD. This is total physical and cognitive incapacitation.
By the late stage, the patient is completely incapacitated. They're often bedridden and entirely dependent on others for every single aspect of care. There's a complete loss of mobility and verbal communication.
And agnosia is complete by then?
Typically, yes. They're unaware of their surroundings. Seizures and tremors are also possible. At this point, management shifts entirely to palliative or hospice care, focusing purely on comfort and safety.
The journey through AD involves such profound loss, and the emotional toll affects both the patient and the family. We need to talk about the psychosocial assessment, which I think is often neglected amid the focus on physical care.
It's so crucial. Both the patient and the family are experiencing a perpetual state of grief. Grief for anticipated and actual losses. For the patient, this can lead to severe depression.
That's a huge risk factor.
It is. And here's an insight that needs to be shouted. Older men with dementia or neurocognitive disorders are at a demonstrably higher risk for suicide. They require specialized mental health screening.
And for the family, they're dealing with the reality of these profound behavioral challenges, including that phenomenon known as sundowning.
Sundowning is that increased confusion, agitation, and restlessness that happens late in the afternoon or evening. Other challenges include aggressive behavior, rapid mood swings, and the paranoia that leads to hiding or hoarding objects.
And there can be other difficult behaviors too.
There can. The patient may also display sexual disinhibition due to decreased frontal lobe inhibitory function, which can be just devastating for the family and very challenging for staff to manage appropriately.
So since we can't fix the structural damage, the strategy is all about optimizing the environment and communication. Let's talk about validation therapy, but I want to challenge the common instinct here. Why is it actually counterproductive to try and reorient a patient who's in that moderate stage?
That's a great question because it goes against our entire human instinct to be factual.
Right.
If a patient is distressed because they're looking for a mother who died 20 years ago, our instinct is to say, your mother is dead, you are 85 years old.
But that doesn't work.
In moderate to severe AD, the ability to process new, complex, or contradicting facts is destroyed. Arguing with them only causes increased anxiety, agitation, and aggression.
So what does validation therapy do instead?
It addresses the underlying emotional need. If they're looking for their mother, what they're really looking for is safety, comfort, or something familiar.
So you validate the feeling, not the fact.
Exactly. The caregiver uses validation therapy by acknowledging the feeling. Your mother sounds lovely. What did she look like? This shifts the focus from the cognitive error to the emotional state, maintaining dignity and reducing their distress.
For moderate and late-stage AD, emotional safety trumps factual reality.
It has to.
Structuring the environment seems equally vital for safety and reducing confusion.
It is. It's all about reducing stimulation and maximizing predictability. You maintain a strict, structured daily routine, use visual aids like large face clocks and calendars with neutral backgrounds.
Lighting is important too.
Absolutely. Ensure lighting is adequate but non-glare, especially at night, to reduce confusion and the effects of sundowning. We need to minimize noise and avoid visual clutter that could be misinterpreted as a threat, given their agnosia and spatial deficits.
And what about when you're dealing with the high risk of wandering and falls?
Safety is the absolute priority, and non-restraint measures are always the standard of care.
So not tying them to the bed?
Never. This means using bed or chair alarms, avoiding physical restraints, which ironically increase agitation and injury, and ensuring exits are secure.
And technology can help.
Assistive technologies like sensor lights or grab bars have been shown to reduce falls in this vulnerable population by up to 50%. The strategy for a wandering patient is always redirection, offering a purposeful activity, never confrontation.
Finally, let's touch on the pharmacological approach. Let's simplify the chemistry behind the two main types of drugs.
Okay. The first type, cholinesterase inhibitors, like the drug Donepezil, they essentially protect the scarce supply of acetylcholine, that memory chemical. They try to boost the signal from the surviving neurons.
And the second type.
The second type is represented by a drug called memantine. It's known as an NMDA receptor antagonist. Instead of dealing with acetylcholine, it blocks excess amounts of another chemical, glutamate.
And glutamate is bad here.
Glutamate is excitatory, and in high concentrations it can be toxic to already vulnerable nerve cells. So by blocking it, memantine helps slow the overall pace of neuronal deterioration.
So one drug saves the memory signal, and the other drug minimizes collateral nerve damage.
That's a good way to put it.
The recent controversy around aducanumab, that monoclonal antibody that reduces amyloid plaques, it just shows how challenging AD treatment remains, as its clinical benefit is still really hotly debated.
Exactly. While the mechanism of clearing plaques is appealing, the clinical outcome, a demonstrable improvement in cognition, has been less clear. It just reflects the complexity of trying to reverse decades of structural damage.
Okay, that covers the cognitive destruction of AD. Now let's pivot our focus entirely to part 2 and examine a disease that fundamentally attacks the ability to move. Parkinson's disease.
Right.
Parkinson's disease, or paralysis adjutans, is characterized by the inability to initiate and control voluntary movement. It's a profound failure of the body's
Exactly. The excitatory neurotransmitter, acetylcholine, which stimulates muscle tone and movement, is left completely unchecked. This unopposed excitation of neurons leads to the inability to control or initiate refined voluntary movements.
And that results in the rigidity and tremor that are so characteristic of PD.
Correct.
We also see the presence of abnormal protein clumps here, a bit like in AD, but these are called Lewy bodies. What role do they play?
Lewy bodies are abnormal deposits of protein inside the nerve cells, especially in that substantia nigra. While their presence is linked to the body movement abnormalities, their deposition throughout the brain is also strongly correlated with the later development of dementia.
So it ties the movement disorder to a cognitive risk down the line.
It does.
This pathology results in the 4 cardinal symptoms, which are easy to remember using the acronym TRAP.
Right. T stands for tremor. This is a resting tremor, which means it's most pronounced when the limb is relaxed. It's often described as a pill-rolling motion, and it usually starts on one side.
R is for rigidity.
R is for rigidity, muscle stiffness that's present throughout the entire range of motion.
A is akinesia or bradykinesia.
A is for akinesia, which means no movement, or bradykinesia, which is slow movement. This slowing impacts everything: walking, talking, even facial expression.
And P is the big one for safety.
P is for postural instability. This leads to impaired balance and coordination, making falls a critical high-frequency risk, especially in the mid to late stages of the disease.
I want to challenge a perception here. If the tremor is the most recognizable public symptom, is it the rigidity or the bradykinesia that's actually more debilitating for the patient in their daily life?
Oh, absolutely. The tremor is often an annoyance, but the rigidity and bradykinesia are what truly strip a person of their independence.
How so?
Rigidity causes constant pain and stiffness, and bradykinesia prevents them from initiating movement, which leads to a slow, shuffling gait, difficulty turning, and these terrifying freezing episodes.
And when you can't move quickly to maintain your balance, you fall.
That's it, you fall, and falls are the greatest long-term threat.
And the sources emphasize that these movement problems are often preceded by non-motor symptoms for years. What should listeners be watching out for as early warning signs?
The non-motor symptoms are the key insights that so often go unrecognized. Persistent, chronic constipation is very common. So is hypophonia, which is a soft, monotonous, difficult-to-hear voice.
What else?
Micrographia, abnormally small and cramped handwriting, is another early sign. Loss of smell or olfactory dysfunction is incredibly common, and severe sleep disturbances, including vivid nightmares and acting out dreams, can appear a decade before any movement symptoms.
A whole decade. That's incredible.
It is. The cause is still largely unknown, but the consensus really points to a combination of genetic predisposition, especially mitochondrial DNA variations, and environmental factors.
And again, the environment provides some pretty stark risk factors, often linked to chemicals.
Yes, chemical exposure is strongly implicated. The use of pesticides, herbicides, and industrial chemicals increases the incidence.
And this is a major issue for veterans.
It is. For military veterans, particularly those exposed to Agent Orange during the Vietnam War, PD is recognized as a major risk factor. It affects over 100,000 veterans. And we also see TBI increasing the risks, again, just underscoring this CNS vulnerability to physical trauma.
The progression of PD is often mapped in 5 stages, which define the patient's functional independence.
Right. Stage 1 involves minimal unilateral symptoms, often just a slight tremor in one limb.
Stage 2.
Stage 2 is mild. The symptoms are now bilateral on both sides, and the patient may exhibit that classic mask-like face and a characteristic slow, shuffling gait.
And in stage 3, the falls start to become a major issue.
That's right. Stage 3 is moderate, and it's marked by significant postural instability, where the risk of falling begins to dominate their life. By stage 4, symptoms are severe akinesia, and rigidity mean the patient requires significant assistance.
And stage 5 is total dependence.
Total dependence. The patient is bedridden and requires total care.
So the overarching management goal is to maintain the patient's functional mobility for as long as possible. And the pharmacological strategy seems pretty simple. Replace the missing dopamine.
That's the goal. And the gold standard drug is levodopa-carbidopa.
Why are they always combined like that?
Well, levodopa is the precursor to dopamine. It can cross the blood-brain barrier. However, if you give it alone, much of it gets converted to dopamine outside the brain, which causes side effects and wastes the drug.
So carbidopa is like a bodyguard.
It's a bodyguard. Carbidopa acts as a protector, inhibiting the premature breakdown of levodopa so that more of it can reach the brain to be converted into the usable dopamine that's required for movement control.
When is it usually started?
Usually once the symptoms interfere significantly with their daily activities.
We also have drugs that skip that whole conversion process and just mimic the dopamine signal.
Those are the dopamine agonists, like pramipexole. They stimulate the receptors directly. They're often used early in the disease, particularly in younger patients, to try and delay the start of levodopa, which tends to lose efficacy over time.
But they have their own risks.
They do. They carry risks of their own, including these involuntary, uncontrolled movements known as dyskinesias and a high incidence of orthostatic hypotension.
One of the most heartbreaking aspects of managing PD is that fluctuation in mobility, where the drug works well for a few hours and then suddenly the patient is off.
That fluctuation is the off-time phenomenon, and it is the most distressing symptom for many patients. They transition abruptly between periods of good motor control, or on, and periods of severe bradykinesia and rigidity, off.
That must be terrifying.
It is. Managing these fluctuations often involves adding other drugs like COMT inhibitors, which can stabilize and prolong the effect of the levodopa.
And when tolerance builds, which often shows up as acute confusion or psychosis, sometimes the patient has to essentially detox from the drug.
Yes, it's called a drug holiday. It's a high-risk procedure, typically lasting 3 to 10 days, and it's done under close supervision in a hospital setting.
And the goal is what?
The goal is to reduce the toxicity and tolerance that the patient has developed. It allows the body's receptors to become more responsive when the medication is reintroduced. But symptoms worsen dramatically during this period, which just underscores their dependency on the drug.
When the drugs plateau or the side effects become intolerable, surgical intervention is the next step. What are the 2 main ways we use physical intervention to control movement?
The older, more invasive technique is the stereotactic pallidotomy. This uses targeted heat destruction to destroy specific areas deep in the brain, like the globus pallidum.
And the goal there is just to interrupt the bad signals.
To interrupt the excessive excitatory signals that are causing the dyskinesias, the stiffness, and the tremors.
And the more modern reversible procedure is an implantable device.
That's deep brain stimulation, or DBS. Electrodes are surgically implanted into specific brain targets, and they're connected to a pulse generator, like a pacemaker, under the skin.
And it sends a current.
DBS delivers a continuous, low-level electrical current. This current acts as a regulator. It helps to modulate the involuntary movements, significantly reducing dyskinesias, and it often allows patients to reduce their levodopa dosages.
Which in turn reduces the side effects.
Exactly.
The contrast between the structural collapse of AD and the chemical imbalance of PUD gives us a strong foundation. But now let's leave the world of chronic degenerative disease and move to the acute events that hit the central nervous system slightly. We'll transition to part 3, starting with the sudden electrical storm of epilepsy.
Okay, so a seizure is the functional event itself. An abnormal, sudden, uncontrolled electrical discharge of neurons.
And this results in temporary changes in consciousness, sensation, or motor ability.
Correct. Epilepsy is the diagnosis. It's a chronic disorder that's defined by repeated, unprovoked seizure activity.
The modern classification system divides seizures based on where they start in the brain.
Right. We categorize them into broad types. Generalized seizures involve both hemispheres of the brain simultaneously.
And the classic example is the tonic-clonic seizure.
The tonic-clonic seizure, which used to be called a grand mal, this involves the tonic phase muscle stiffening, rigidity, often followed by the clonic phase, which is that rhythmic jerking of all the extremities. Consciousness is lost, and incontinence often occurs.
Then we have the partial seizures, which are more focal.
Partial seizures begin in just one cerebral hemisphere. The complex partial seizure is a fascinating one because the patient loses consciousness, but only for maybe 1 to 3 minutes.
And they display these automatisms.
Yes, these repetitive, unconscious behaviors like lip smacking, picking at their clothing, or just wandering aimlessly. And the patient is completely unaware during the whole episode.
Here's a great example of the brain sending an early warning signal, and it connects back to what we're going to talk about with migraines, the aura.
An aura is a vital insight. It's a temporary, subjective sensory or visual change. Smelling a strange odor, seeing flashing lights, or experiencing a sense of impending doom that precedes a seizure or a migraine.
So it tells the person that the brain's electrical system is about to overload.
It's their warning. Simple partial seizures often begin with an aura, and the patient remains fully conscious while they're experiencing this strange sensation.
What sparks these electrical short circuits? What causes them?
They're classified as either primary, which is idiopathic, meaning no known cause, or secondary, meaning they are a symptom of something else.
And the secondary causes are really diverse.
Incredibly diverse. They can include brain trauma, lesions, tumors, stroke, severe metabolic disorders like low sodium, or withdrawal from alcohol or certain sedatives.
And in older adults,
New onset seizures must trigger a hunt for underlying conditions like heart disease or a recent stroke.
we have to emphasize the severity of status epilepticus. Why is a seizure lasting longer than 5 minutes a genuine life-threatening emergency?
Status epilepticus is catastrophic because the brain's demand for oxygen and glucose during a seizure is astronomically high. When the seizure lasts longer than 5 minutes, the body's resources are just quickly depleted.
And that leads to brain damage.
It leads rapidly to anoxia, lack of oxygen, to the brain's severe metabolic acidosis, hyperthermia, and exhaustion. If it's not stopped immediately, this cascade causes irreversible brain damage or death.
So what's the rapid-fire intervention sequence to stop this crisis?
Immediate, aggressive drug therapy is required. First, we use fast-acting 5-E benzodiazepines, typically lorazepam or diazepam, to stop the seizure activity.
And then something to keep it from coming back?
They're followed immediately by a longer-acting drug like phenytoin or fosphenytoin to achieve sustained seizure control and prevent recurrence while we search for the underlying cause. Time is literally brain tissue in this situation.
During any seizure event, safety protocols are strict, especially concerning common misconceptions about what people should do. What are the absolute do's and don'ts?
The absolute priority is injury prevention. Clear the area of objects, loosen any tight clothing around the neck. The patient must be turned onto their side immediately, the recovery position, to prevent aspiration of saliva or vomit and keep their airway patent.
And the 2 critical don'ts.
Never force anything into the patient's mouth. You risk breaking their teeth or causing a jaw injury. And never restrain the patient's movement. You simply guide their movements gently if they're near a dangerous object, but never try to stop the convulsions.
And meticulous documentation is essentially the diagnostic tool, right?
Yes. The observer must note the precise time of onset and duration, the specific type of movement, tonic, clonic automatisms, and whether an aura was present. This information is indispensable for an accurate diagnosis and for long-term treatment planning.
Okay, now we shift from the body's electrical system to the threat of external microbial invasion. Let's tackle meningitis, an infection that strikes the delicate protective layers of the brain.
Meningitis is the inflammation and infection of the meninges, which are the protective coverings of the brain and spinal cord, specifically the pia mater and arachnoid layers.
And organisms get in how?
Infectious organisms, bacteria, viruses, fungi, or protozoa, they gain access, usually via the bloodstream from a distant site like the sinuses or the lungs, or they can get in directly through a portal created by trauma or brain surgery.
We often hear about the differences between viral and bacterial meningitis.
Right. Viral meningitis or aseptic meningitis is the most common form. It often causes less severe symptoms, and it usually resolves without any specific treatment.
But bacterial is the dangerous one.
Bacterial meningitis, however, caused by organisms like Neisseria meningitidis or Haemophilus influenza, is highly dangerous, carries a high mortality rate, and requires immediate aggressive intervention.
Which populations are critically vulnerable to these most dangerous bacterial forms?
Risk factors include being immunocompromised, older adults, and, crucially, young adults aged 16 to 21. They're at the highest risk for N. meningitis and infection, often due to living in close quarters like dormitories.
So any break in the barrier is a risk.
Any direct communication route, like a basilar skull fracture that allows cerebrospinal fluid to leak, creates an immediate entry point for infection.
When you're assessing a patient, what are the key clinical findings that just scream meningitis?
The clinical presentation is severe and unmistakable. Key assessment findings include a rapidly decreased level of consciousness and disorientation.
And the physical signs?
The hallmark physical signs are a severe, unrelenting headache, often described as the worst headache of their life, photophobia, which is extreme sensitivity to light, and classic neutral rigidity, a stiff neck that makes it painful or impossible to touch their chin to their chest.
And you're also watching for brain swelling.
We're monitoring very closely for signs of increased intracranial pressure, or ICP, as swelling of the brain tissue within the rigid skull can quickly become fatal.
Given the speed of bacterial infection, what is the priority intervention strategy?
Speed is everything. Immediate interventions prioritize frequent neurologic status checks and vital signs monitoring, often every hour or even more frequently, because changes in mental status can signal rapidly rising ICP.
And you have to start antibiotics immediately.
Crucially, we have to establish IV access and begin IV antibiotics before we even get the final culture and gram stain results back. Delaying antibiotics for bacterial meningitis increases mortality exponentially.
Okay. And you're managing pain and fever.
We manage fever and pain aggressively and continuously monitor for complications like shock or seizures.
And finally, transmission precautions are essential for containment.
For bacterial meningitis caused by N. meningitis or H. influenza, droplet precautions must be initiated immediately. This means the patient must be in a private room, and staff and visitors have to wear a mask when working or standing within 3 feet of the patient to prevent transmission via respiratory droplets.
We've mapped the chronic degeneration and the acute invasion. Let's conclude this deep dive by focusing on the neurovascular system and the common yet devastating pain syndrome, the migraine.
Right.
A migraine is so much more than a headache. It is a complex, recurrent neurological syndrome. The pain is usually throbbing, unilateral, and lasts between 4 and 72 hours.
And what really defines a migraine is its accompanying sensory features.
Mm.
Intense nausea, vomiting, photophobia, that light sensitivity, and phonophobia, sound sensitivity.
This pain is caused by a complex, localized vascular storm, not just simple tension. Let's simplify the pathophysiology for the listener.
The widely accepted theory involves the activation and sensitization of the trigeminal system, or TVS. This is essentially the pain-sensing network surrounding the brain's blood vessels.
And when the TVS is activated,
It sets off a chemical fire alarm, and it releases potent neuropeptides. The most notorious of these is calcitonin gene-related peptide, or CGRP.
CGRP sounds like the central villain in this story. What does it do?
CGRP is a powerful chemical messenger that acts as a potent vasodilator. It tells the cranial arteries to just swell up dramatically.
And that causes the pain.
That vasodilation, combined with the subsequent local inflammation, causes widespread tissue swelling, which in turn sensitizes the surrounding nerves. That resulting inflammation and pressure is the source of the intense, throbbing, pulsating pain felt during a migraine attack.
So, if the TVS is the switch and CGRP is the explosive agent, what flips that switch? What are the common triggers?
Triggers are highly individualized, but they generally fall into environmental, physiological, or dietary categories. Environmental triggers include high-intensity light, noise, stress, excessive fatigue, or even barometric pressure changes from the weather.
And certain foods.
Certain foods, often those containing tyramine-like aged cheeses, smoked meats, red wine, and beer, or chemical additives like MSG and artificial sweeteners.
Skipping meals is also a very common physiological trigger.
Migraines are classified primarily by whether or not they are preceded by a temporary neurological disturbance. Right. We have migraines with aura, which are classic, and migraines without aura, which are common.
Let's detail the full progression of a classic migraine, which happens in 3 distinct phases.
The attack often begins 1 to 2 days before the pain, with the prodromal phase. These are subtle, non-specific changes. Excessive yawning, unusual constipation, unexplained mood changes, or intense food cravings. This phase is often only recognized in hindsight.
Then comes the aura, the neurological event itself.
The aura is the temporary central nervous system symptom, and it lasts 5 to 60 minutes. It's often visual, involving positive symptoms like shimmering zigzag lights, lines, or blind spots.
But it can be sensory, too.
It can be. It can cause temporary numbness or tingling of the face and hands, vertigo, or even transient aphasia, which is difficulty speaking. It's the brain signaling distress.
And finally, the migraine phase is the headache itself, which is the full culmination of that CGRP-driven vascular cascade.
Correct. The pain peaks here, unilateral, pulsating, throbbing, and it's accompanied by the intense sensory sensitivities, photophobia and phonophobia, and the GI distress like nausea and vomiting. This phase can be completely debilitating and is what drives patients to seek relief. It can last up to 3 days.
So the management targets are twofold: aborting the acute attack or preventing its recurrence. Let's start with abortive drug therapy, which has to be taken early.
For mild or infrequent migraines, over-the-counter NSAIDs or acetaminophen, often combined with caffeine, can be effective. However, for moderate to severe attacks, the main agents are the triptans, like sumatriptan.
And triptans are crucial because they directly target that chemical cascade.
They do.
How do they stop the throbbing pain?
Triptans are serotonin receptor agonists. They work by directly constricting the dilated cranial arteries that were blown open by the CGRP. By reversing that vasodilation, they interrupt the pain cycle.
But timing is everything.
The key teaching point is that they must be taken during the aura or immediately after the onset of pain. If you wait until the pain is severe, they are far less effective.
This drug mechanism, vasoconstriction, demands a very serious warning. Who should never take triptans?
Anyone with existing vascular risk factors. Triptans are absolutely contraindicated in patients with actual or suspected ischemic heart disease, uncontrolled severe hypertension, Prinzmetal angina, or cerebrovascular ischemia.
Because they could cause a stroke or heart attack.
Since they constrict cranial arteries, they pose a risk of coronary artery spasm or stroke in these vulnerable populations. And furthermore, triptans must be avoided by pregnant women.
If the migraines are frequent, say more than twice a month, or if they severely interfere with life, the strategy shifts to preventive drug therapy.
Prevention focuses on making the neurological system less excitable. Older methods involve repurposing drugs like beta blockers, like propranolol, and calcium channel blockers, like verapamil. They stabilize blood flow and neuronal excitability.
And anti-epileptic drugs, too.
Certain anti-epileptic drugs, like topiramate, are also used because they dampen the hyperexcitable neurons that initiate the migraine cascade.
But the truly revolutionary drug class targets CGRP directly, right?
Yes. The newest treatments are monoclonal antibodies that specifically target the CGRP receptor or the CGRP molecule itself. By neutralizing CGRP, you stop the chemical fire alarm before it can set off the massive vasodilation and inflammation.
And these have shown incredible promise.
They have, especially in chronic migraine management.
Beyond pharmacology, what non-drug strategies show the most promise for reducing the frequency and severity of attacks?
Integrative management focuses on reducing generalized CNS excitability. So biofeedback, meditation, yoga, and regular consistent exercise are all effective by managing stress and reducing the frequency of triggers.
And what about cannabis?
The sources highlight that medical marijuana, or cannabis, has shown very promising results in studies with reports of reducing migraine severity by up to 50%.
And there are devices, too.
Yes, there are non-invasive devices, like the external trigeminal nerve stimulator, or ETNS, which delivers electrical stimulation to the trigeminal nerve to interrupt the pain signals.
That brings us full circle, from the slow collapse of memory to the acute, sudden pain of a neurological event.
It does.
We have completed an exhaustive deep dive into the central nervous system today. We began by charting the devastating chronic course of AD, defined by the failure of structure, those plaques and tangles, leading to the irreversible loss of cognition.
And we followed that with the chronic chemical failure of PD, where the loss of dopamine means the brake pedal is removed, leading to unopposed excitation, rigidity, and the loss of controlled mobility.
We then explored the acute threats, the electrical system failure in epilepsy requiring immediate anti-seizure intervention and strict safety during a seizure.
The critical, life-threatening CNS infection of meningitis, demanding rapid 4V antibiotics and droplet isolation.
And finally, the vascular event of the migraine, a pain syndrome driven by that explosive chemical, CGRP.
And what connects all our management strategies, whether they're structural, chemical, or acute, is the overriding priority of maintaining safety and functional capacity.
Right.
From using validation therapy to keep an AD patient calm, to optimizing levodopa timing to keep a PD patient walking, and ensuring the airway is clear during a seizure, the goal is always to maximize independence while mitigating risk.
As we wrap up, let's return to that powerful synthesized insight we found in the Alzheimer's research, the linkage between social structures and neurological stability.
Mm,
We discussed how profound, measurable social determinants of health like poverty, chronic stress, and educational inequity are directly linked to an increased risk for neurological disease.
This is a direct challenge to the idea that CNS stability is purely biological or genetic. It is deeply connected to societal structure and access to resources.
So, considering these profound connections, we have to ask, if the stability of the central nervous system across the entire population is tied to health equity, are we looking at social and economic disparities not just as humanitarian crises, but as precursors to a future neurological burden?
That's a powerful question.
Does achieving true health equity mean we are literally building a more resilient, cognitively stable society for future generations? That's a complex societal question that builds directly on the biology we explored today.
Indeed. We encourage you to carry that insight with you.
Thank you for joining us for this essential neurological exploration on the deep dive. We'll see you next time.